and our future. Today, our focus is on the healthcare sector, and we're going to be talking about the pandemic and beyond, and the need for India's healthcare sector to undergo a complete reboot. And just to let you know, this conversation is live on CNBC TV 18's television as well as digital platforms. It's an initiative by the Mind Institute set up by Hero Enterprise. The conversation is also live on Mind Summit's Facebook page. So without further delay, let me welcome my first guest today, Sunil Munjal, the chairman of Hero Enterprise, who also likes to personally curate these Mind Monday conversations. Mr. Munjal, thank you very much for joining us today. First up, I want to begin by asking you, most of us know you as an auto sector veteran, but of course, Hero Enterprise also has some interests in healthcare. Has the pandemic brought about any interesting investment opportunities for you in the healthcare space? Are you eyeing any innovations at this point in time?
So that question is a surprise. But yes, as an active investor, we have looked at health as an opportunity. As you know, we are both involved in not-for-profit health in DMC, Dharan Medical College and Hospital, which is one of the largest teaching hospitals in the country now, which is also focused on research and nursing college and a medical college. But as an investment office, we do look at health as an opportunity. And we do have some investments, especially overseas, in medical devices in California, the cancer drug discovery. And our team is currently looking at where the need and opportunities lie right now. But let me first thank you, Mridu, for anchoring this session of Mind Mondays. As you know, Malcolm Forbes once said, true vision is insight. And this is what we at the Mind Institute try and do, is to provide insight by talking to experts, subject matter experts, and looking at something like, at this moment, a big cathartic event that we are all facing. But since we could not do the physical Mind Summit, which we do every year in April, we are doing this through what we call Mind Next and a series of sessions called Mind Mondays. Today, I'm delighted that we could get such top-class experts, such as Dr. Srinath Reddy, who is the president of the Public Health Foundation of India. And public health, as we know, is one of the subjects and themes that's actively being discussed and debated right now. We also have Dr. Priya Sampathkumar, who is a critical care specialist and head of infectious disease at the Mayo Clinic in the US. And she is a very respected voice in this field and is leading the initiatives on research and ideation on how to address the COVID-19 situation, not just in her institution, but also worldwide. I also want to offer a very special thank you to Dr. Poonam Khetrapal, who is the South Asia head of WHO and a former bureaucrat and a thinking individual who I think is the absolutely perfect person to have on this conversation to discuss where we are today and how do we go forward in this. And to moderate the session, we have Dr. Ambrish Mithal, who is the chairman and head of Endocrinology and Diabetology at Max. He's an old hand at this, one of the most respected voices in India in not just the field of diabetology, but also on healthcare in general. Big thank you to all of you. And I hope in the next 1 hour, part of which we will also see on CNBC. So big thank you also to CNBC for partnering with us on this series where we bring in issues that matter. We've looked at things like hospitality, jobs, economy, and today we are addressing something which is close to everybody's heart and mind, is how do we get through the current situation and where will we land up once we are through this? So thank you very much, Mridu, for that question.
Thank you, Mr. Munjal. And Priya, I want to begin by talking to you. First of all, thank you very much for joining us so early in the morning from the US. Thanks for taking our time. I know it's a very, very busy time for you. First up, purely from a science perspective, this is a very fascinating virus, a virus that has left most of the medical community across the world confounded with its erratic behavior. So far, we know that it's highly contagious. We know that it affects the respiratory system the most. We know that persons with serious health conditions, prior health conditions, are more likely to be impacted by the virus. It has mercilessly claimed lives across the globe. What new have you discovered over the last couple of weeks as far as this novel coronavirus is concerned, and how is it really different from all the previous coronaviruses that we've seen?
So I think the most important thing about this virus is that no one in the world has been infected by this virus prior to this outbreak. So essentially you have the entire world's population susceptible to the virus, and that's what makes this so dangerous. The other thing about this virus is, yes, it's a respiratory virus. It enters our bodies through the respiratory tract. But as time goes on, we're learning that it can pretty much affect every single body system. So you have a pneumonia from the virus. You can have inflammation of the heart and consequences from that, including heart failure and arrhythmias, where your heartbeat becomes very irregular. It appears to affect the GI tract and can give you diarrhea, nausea, vomiting. It affects the brain and can give you encephalitis, memory disturbance, confusion, delirium. So it really appears to be a virus that can go anywhere. The other thing that we've realized is that it can give you unusual skin rashes. It can also give you increased risk of clotting. So it causes so many different issues with different body systems that it is a very unique infection compared to every other kind of coronavirus you've seen. Most prior coronaviruses were really, gave you a minor cold, did not make you very sick, primarily happened in children. By the time people were adults, most people didn't have any significant problems with it. So both the fact that we have a large population that's non-immune, the fact that it can cause very severe illness in some people, including death, and the fact that it can affect every body system, giving you a multi-system illness, is what makes this so unique.
Right. And if I can just bring in Professor Reddy at this point in time. Professor Reddy, can you hear me loud and clear?
Yeah, I can hear you well. Thank you.
We are at over 67,000 COVID positive cases as of today. But how does one really measure the real extent of this pandemic? The eventual goal is, of course, to minimize the loss of lives. But even as testing gets ramped up every day in this country, there are asymptomatic patients, there are the ICU numbers, there are the hospitalization numbers, there are the numbers of the deceased. What is the real extent of this pandemic, and what sort of an exponential increase are we expecting over the next 2-3 months as we slowly lift up the lockdown? We are ready to start passenger trains in a phased manner from tomorrow. Are we really ready to see an exponential rise?
Well, basically, we'll have to look at a multi-dimensional picture, at least a 3-dimensional picture. Firstly, imagine a triangle. At the base of the triangle, which is wide, are a mix of people who are infected and asymptomatic or very mildly symptomatic. Then in the middle of the triangle, you have people who have influenza-like illness and may need to be detected by what's called syndromic surveillance, in which symptom-based surveillance is done by household visits or by telephonic contact. Then at the top of the triangle, you have people who are actually getting admitted to hospital with serious acute pulmonary infection. Some of them, a few of them will die, but many of them will require care in hospital and will recover and get discharged. Now, we need to find out the dimensions in each of these areas. Now, as far as the bottom of the triangle is concerned, it's difficult to test everybody, particularly when many of them are going to be asymptomatic. But you could do random sampling antibody surveys in district level and then try and gauge to some extent what the level of the spread is, though there are likely to be some false positives with antibody tests. In the middle, you can actually do syndromic surveillance based on symptoms and try and identify people with influenza-like illness, as I said, through household or telephonic surveys. And those who report such symptoms can be tested with antigen testing. Then those who are actually admitted in the hospital are going to get tested anyway. and we get full measure of all the three dimensions that way. But we should not get too panicky about how we are actually measuring this epidemic in terms of the spread, because ultimately the objective is to reduce the number of deaths. And when we do that, we recognize that if you take deaths per million population,
right,
we are at the moment having 1.27 deaths per million population, whereas countries which started along with us at the moment have actually gone ahead. The UK, Sweden, and others have
right,
gone into hundreds per million population.
right.
So in that sense,
I'm Professor Reddy, going to come back to you on that bit about what various countries have been doing. But let me also bring in Poonam at this point. WHO, of course, is a crucial partner to the government, to governments around the world, in fact, as we all battle COVID-19. So far, Poonam, what is the WHO's perspective on the steps that India has taken to control the pandemic? We've had about 3 versions of the lockdown, over 50 days of a lockdown, nationwide lockdown in India. And now, as we look at slowly bringing business back on track and we try to balance lives with livelihoods, what are some of the strategic steps that India needs to keep in mind over the next 4 to 6 week period in particular?
India, as we know, has been recognized the world over of having started very well in handling the pandemic, and we are aware of the measures they took right in the beginning. They came in very early, and I think that was a good thing that was done. There were interventions which helped, apart from a very robust contact tracing to the lockdown, which also was considered to be essential at that time. India is now moving on it as we talk. We know the Prime Minister is already consulting the CMs of different states to decide how this should be done. So this whole approach, I think it's not a question of lives. Should it be lives or livelihoods? There has to be a balance between both. There are those that are affected, and we as a country and India as a country needs to see that the very poor are helped out of this situation. Therefore, there is a situation now before India, and it's a tough situation to decide that how should this transition to normalcy be. There has been a little opening of late, like there are some essential services which have opened, and we do hope that some more will be opened, so that gradually those who are without livelihoods do get a chance to earn their living. That we believe is the right way to go, and that is the way India is going at the moment.
Okay, also I want to bring in Dr. Ambrish Mithal at this point. Dr. Mithal, in India, over 50% of all deaths due to communicable diseases in 2018 were due to respiratory disorders and pneumonia in particular. In addition, we have been in the recent past christened as the diabetes capital of the world. So in that sense, would you say that Indians are at a much higher risk of contracting COVID-19? On the other side, we've also been hearing that since we are a young nation and we have the demographic dividend on our side, we are perhaps better placed than a lot of other countries to battle this disease as well.
This is a very fascinating question, Ridu, because the data that's coming in from UK is actually showing the South Asians are the most prone. In a recent study, the average age at admission, hospitalization for South Asians was 61, whereas it was 77 for white Caucasians. The percentage of people who were diabetic in the population admitted in UK in the South Asians was 48%, and it was 28% in the Western Caucasians. And overall, the mortality was more than 1.5 times higher in South Asian populations. So on the one hand, we are saying that in the UK, South Asians seem to be more prone to serious effects of the epidemic, which may be logical because, for example, diabetes is almost double in them as compared to native white Caucasians. Here, on the other hand, we are seeing something very, fingers crossed, something very encouraging. I don't think the serious disease component here is as high as we would have thought. Yes, I do think Indians are intrinsically going to be if we get affected more and more, we will get more serious disease. Remember, at the age of 60, in metros like Delhi, Bombay, Chennai, almost 40% population is already diabetic. So if you're talking of people at 65, 70 being in any case at much greater risk, almost half of them may be diabetic. So really, if it starts affecting that segment of population in our country, I think we'll be in trouble. But so far, it seems that we've been quite lucky with this. So I hope that continues. And I don't think scientists clearly understand the reasons for the differences, and we can discuss this as we go on. The real reason why South Asians in UK should behave differently from Indians in India.
Right. And Dr. Priya, if I can come back to you, the pandemic numbers, especially from the US in terms of fatalities as well as the positive cases, have really been terrifying. Do you think it could have been handled better by the government? They didn't really take it very seriously at the outset. So did you lose out on precious time at that point in time? And what's the near future looking like?
So definitely there were a lot of missteps in the United States. We had a nice window of opportunity of over 2 months where things could have been put into place, both for testing and contact tracing, limiting the spread of infection. And we missed that window. And primarily because testing was delayed by so much, we ended up with huge numbers of cases in our major metropolitan areas in Seattle, in California, and then, of course, New York, which has become the epicenter in the US. So the lack of testing, we had this sense of security that we actually didn't have cases, when now it appears that we definitely, as early as January, had a number of cases and community transmission happening even at that time. So the lack of testing was one thing. The lack of sounding the alarm that, you know, hospitals really are going to get surges of cases and that you need to be prepared was also a problem. And that was what led to the huge numbers of deaths in New York, because the medical system just quickly got overwhelmed and we're not able to provide good medical care in the ICUs. And the third thing, which, you know, really as an infection prevention person is very, very disheartening, is the lack of PPE. In the United States, which is, you know, got a lot of resources, not having adequate PPE, having to reuse things that we have never had to use more than once in our hospitals, and lack of training for the staff and how to put on and take off their PPE were huge missteps in the US.
Right. And Professor Reddy, final question to you as we end the TV bit of this discussion. Is India really prepared? Is our public healthcare system really prepared for the pandemic, the peak that's perhaps coming our way over the next couple of months? And is it time to perhaps rope in the private sector in a much bigger way and put those public-private collaborations in place? What are those looking like at this point in time?
Well, I think we have spent a fair amount of time during the lockdown in preparing. Even earlier, I think once we started the containment measures, even by middle of January, and then stepped them up by February, I think the preparations went up. We too faced several challenges in getting access to testing kits as well as personal protection equipment. But I think over a period of time, we have actually garnered the resources. Ultimately, a response to the pandemic in any country depends upon recognition, resolve, resources, response, and resilience. Resources, we have not had a plenty, but there was early recognition, there was clear-cut resolve, and we have garnered the resources. We have provided a stepped-up response in different stages, and now I think we'll have sufficient resilience if the virus decides to strike back with ferocity later in the year, but we still have to maintain our vigil even till that time. So I believe we need to, even in the post-lockdown period, maintain physical distancing, masks, as well as hand hygiene, and ensure that we do not give the virus a free highway to speed around.
Right. Well, thank you very much, Professor Reddy. And it's a wrap of this conversation on CNBC TV18's television platform. But of course, we are continuing the conversation on our digital platforms, on social media, Facebook, Twitter, CNBC TV18 handles, as well as the Mind Summit Facebook page. So those of you who are just joining in, we may continue the conversation and make it a lot more interactive on our digital media. And for our television audience, thank you very much for joining us today. Mind Mondays will be back next time. Thanks for joining us. Goodbye. And for our digital audience, here we are, Mind Mondays. Our conversation today is on the healthcare sector. We are talking about the pandemic and beyond, and if India's public healthcare system needs a complete reboot or not. And I'm joined by a very eminent set of panelists today. And for the digital version of this conversation, I'm going to hand it over to my co-moderator, Dr. Ambrish Mithal, who's a very, very renowned diabetologist as well as endocrinologist. He's the chairman and head of endocrinology and diabetology at Max Healthcare. Dr. Mithal, over to you to fire the next round of questions to our panelists.
Thank you, Mridu. And as we continue this conversation, I will go to Poonam now. Dr. Poonam Khetrapal, do you feel that intermittent complete lockdowns is a valid strategy if the virus reemerges, or you believe it has to be a graded lifting and then differences in gradation, or do you feel there could be a need for a complete lockdown again?
Well, I do believe, Dr. Mithal, that if the lockdown hadn't come when it came, there would have been many more cases. That is something that goes without saying. We would have had many, many more cases. However, now that the lockdown has been there for almost 6 weeks, and even more, I mean, it's 7 weeks now, and we are reaching a stage where we need to advise India on whether the lockdown should be there or should be lifted. Our view is that it should be a gradual lift. And that gradual lift would help us to see what the effect of the opening up of the lockdown is. We are already seeing that as the lockdown has been lifted in the last few days, we do find much more activity. And I think that a graded kind of a gradual getaway from the lockdown will help much more than an immediate lockdown, because to go back again to a lockdown may be much more harmful. Now, we've seen countries in the world doing that. South Korea was cited as an example, so was Germany. But we find that now South Korea is going back into a lockdown after having lifted the lockdown for a very long time. And therefore, they didn't have a lockdown, in fact. They allowed people to go around, but they had a very, very intensive testing strategy. But now Korea does believe that, yes, they may need to go into a lockdown. And that is what we learn from many countries around the world. So I think what's very important is to bring in the intervention early, to bring in the intervention at the right time, and then to take your time and decide on how to gradually move out of it, because that is the way to go forward. This is a virus which people don't know much about even today. There are huge gaps in knowledge as far as this virus is concerned. And therefore, in a situation where there are still these kind of gaps, it becomes very important to be gradual when we are exposing a lot of people to a situation where they may get infected. There would be a surge of cases as the lockdown is lifted. There's no doubt about that. There would be a surge of cases. But I think the government of India has taken its time to prepare for it. This was a long time to see that, yes, they had the right equipment, they had the right PPEs, they had the diagnostics. And of course, this needs a whole of government approach. It also needs a whole of society approach. It needs community participation. Each and every person has to understand that, yes, even if the lockdown is lifted, they need to maintain social distance. They need to maintain their masks. as they move around. They need to sort of wash their hands frequently. All that they were doing during the lockdown to protect themselves and to protect others needs to continue. So I think that's something that every individual needs to understand, especially at the community level, and especially in those areas which are very congested in the urban areas. And I'm referring to the urban slums where we have a high density of populations. This is something that needs to go across to all. There has to be awareness of this virus and how, this virus can hit back if there is a loosening of these kind of measures that have been adopted during a lockdown period.
Thank you. And we move to Dr. Priya again. And Priya, I'd like to ask you, what is your understanding of herd immunity? Do you think that herd immunity for COVID-19 could be a serious strategy? I mean, as a strategy, I know that at some point we think herd immunity will take over and something, we'll all be immune, like as happens with other coronaviruses. But do you really feel that herd immunity as a strategic approach to battling this virus is a sensible one? And what are the pros and cons there?
So definitely herd immunity is what's going to finally, stop this outbreak. The problem is, how do we get to herd immunity? Everything that we're doing right now with the lockdowns, the social distancing is to limit the number of cases. And when you have fewer cases, you have less people infected, therefore you have less herd immunity. Really, the only safe way to get herd immunity is through vaccines. And unfortunately, making a vaccine takes time. So if we're going to depend on the vaccine to give us herd immunity, we're probably looking at maybe 12 to 18 months from now. So we're a long way from achieving herd immunity through vaccines. And there's really no safe way to get herd immunity without that, because everybody is reacting differently to the infection. As you said, South Asians in the UK have had a very high infection rate, mortality rate. And I wonder if part of that is the fact that they were all healthcare workers and maybe had a much higher viral load, a bigger exposure to the virus. But we really don't know so many things about it. Is there an infective dose? If so, what is it? Can low-grade infections, do they give you durable immunity? Does that immunity last 1 season, 2 seasons? How long does it last? So too many unanswered questions for us to really make sense of the data as of now.
And you do believe, as most of us do, that a vaccine at the very earliest will take at least 12 months, probably 18 months, even from now. There is this hope that, I keep trying to explain to people that vaccines are given to normal people. Anything that's administered externally to normal people has to be tested very rigorously for safety, as opposed to a drug which is given to someone who's diseased. So therefore, I think vaccines, you're absolutely right, will take time, and herd immunity. Ultimately, that is the time when one can literally breathe a little easier. Until then, we have to be really extremely alert and observe all precautions to keep this virus at bay.
If I might just add, Dr. Mithal, if I might just add one of the audience questions that has just come in, which is on herd immunity. And Karthik asks, will developing herd immunity without the vaccine lead to a high mortality rate?
Yes, Priya, you want to take that?
Yes, I think so. Well, because you can't, say I'm going to infect all the healthy people. The infection will spread through populations, and populations consists of young people, older people, and so definitely trying to get herd immunity through infection will result in the short term in very high mortality.
So I'll move to Professor Reddy again now, and one of the challenges has been to explain the differences in the way the virus has behaved in different countries, and then to extend that to within India, but we'll come to that later. But between countries, what are the key differences? Is it just the approach of the particular nation, a particular government, particular population? Or is there something else that determines the striking differences in mortality and the impact of the virus across the world? Dr. Reddy, please.
I believe, firstly, in terms of how the actual epidemic spreads, we have to look at socio-demographic factors, climatic factors, and immunity-related issues. In terms of socio-demographic factors, we have to look at the age structure as well as the urbanization. For example, most of our South Asian neighbors too have had very low rates of mortality. And the possible explanation is that apart from a favorable age structure of a younger population, we also have a very large component of rural population, where the virus spread is usually less. The R0 or the RO, whatever you want to call it, is the infectivity rate of the virus, how many people it infects, is actually much less in rural areas where the mobility is much less and the community is much closer, but nevertheless not very mobile. And therefore, that's another factor that we need to look at in South Asia. Second is the climatic factor, whether heat and humidity actually reduce the spread and virulence of the virus. We have no clear-cut proof for that, but that's a possibility that we need to consider. Third is immunity, innate or acquired. Acquired, of course, comes with exposure to the virus, but do we have some additional elements favorable to us because of our long-standing record of BCG immunization as a non-specific immunity booster of innate immunity, or the same purpose served by our polio immunization program, as has been suggested, or different explanations like even malaria endemicity. All these are hypothetical. We have no proof yet. But then if there are factors that are actually contributing additionally to some degree of innate immunity, it might work in our favor. But certainly the health system response and the general response also matters. If you have delayed your lockdown, if you have ignored your social distancing, like Sweden initially was celebrated for having said we are not going to go for a lockdown or social distancing, but now they're paying the price in terms of higher death rates compared to, for example, Denmark. So I think there's a multitude of factors that goes into how an epidemic actually affects the population.
I'll continue with you for a minute, and I think we need also to understand a little better the differences within India. It seems that, some states are behaving differently than others. It could be linked to movement of populations. It could be linked to ports being there. It could be linked to the main airports being there. It could be the crowding in a particular area. But quite clearly, different states seem to be doing differently. Not all are doing the same way. Some of this, I believe, is definitely a reflection of the healthcare system of the state. And we know state is a health subject ultimately. Health is a state subject ultimately. So it's definitely that some states may be different than others. Do you feel that the public health system of some states is doing better than others? Or do you think it's just a good immediate management or management right now that's making a difference? Or where do you place the role of private players? And then I'll come in on that.
Undoubtedly, the health system matters. If you have a public health system and a healthcare system that are functioning very well in the steady state, then when challenged with a public health emergency, you can quickly raise the surge capacity to meet with it. Now, if you have weak health systems which are floundering even during routine times, then they are going to struggle when it comes to meeting a public health emergency. The southern states in general have fairly well-functioning health systems, though there are variations among them. You have Kerala as an outstanding example, Tamil Nadu in general, Andhra Pradesh, Telangana, and even on the eastern side, Odisha, Karnataka. So these are the states which generally are expected to do well, and they are doing well. Now, it is also true that some of the eastern states and northeastern states have not yet been challenged because they have not had large influx of foreign return travelers with very few airports, very few international flights, and a much more rural population. But if they do get challenged, there's going to be a serious problem because their health systems in general have not had a very good track record in the past. But certainly, we do need all societal resources, public and private, to be mobilized very well in synergy in order to meet this rather unprecedented challenge to the health system.
So I'll put in a few words about the challenges that some of the private healthcares at different levels are facing, because every other day you'll read something about private healthcare should step up. So it's a bit unclear as to how private healthcare should step up. And let's look at this at different levels. If you look at the larger hospital level, the policy framework of the government has to be clear. One perhaps very good model is the UK model in this, the way they've taken over private hospitals, not taken over, enlisted private hospitals, so that the services are provided by the hospital. There is no profit. It is no profit, no loss basis. And the bills are taken care of by the government. So government is running the private partner is running the hospital on behalf of the government. There is no profit that goes into anybody's pocket, but the government pays for it. That is enlisting. The other way, of course, is to try and do, maybe one state, Maharashtra is trying to do that, is completely sort of say no, all COVID and non-COVID patients will be dealt with in the same way in terms of rates, and all the rates have been frozen. I don't think personally that just instructing hospitals that all your rates have changed today and all COVID and non-COVID patients will be dealt with the same way, at the same rate, and you continue to provide the services you were. I doubt it if that's going to work very well, but that's one model that a state has followed. Maybe it will, I don't know, but I'm skeptical about that. At a smaller level, at a smaller town level, there are huge challenges. People who run small nursing homes and others, doctors, are scared. They don't know because the goalpost is shifting every day. On the one hand, they're told you cannot, if they get one COVID patient in or a health worker, the whole hospital is closed down, and it's in the newspapers, headlines every day. If they refuse patients, then again they're liable, because how can you refuse a patient? So you can't. The testing is not so easily available everywhere. So to say that you cannot test, you cannot decide, it's changing. And I understand it's changing every day because the situation is changing, because the resources are changing, but it's a big factor. And at a very mundane level, what may sound, but what is a backbone of our healthcare system is a general practitioner. A typical general practitioner would be seeing 100 patients a day in a small clinic. Now, if there's no way there can be social distancing there. If the person goes there and starts work, it's a problem. You're exposing, all others and yourself. And if you don't start, it's a problem. Where will those people go for their healthcare? In small towns, there's a big problem about this. People don't know where to go for their healthcare, and especially non-COVID healthcare. That is taking a beating. So I think these policies have to be sort of formed up. I think they're changing rapidly and clearly. Sometimes, even if they are, the message is not going down to the final common path, that is the district administration. And some SDM will suddenly order, lock down this hospital, close this. Headlines will say, COVID found in this hospital, corona positive. So we have to engage with private sector as partners. You cannot arm twist beyond a point for them to really join the battle. I am very hopeful because the health minister himself is a doctor who is very sensitive to doctors' needs, as he has shown in the past. So I'm hopeful that this will get sorted out. But if the private sector is required to come in full swing in this, it is very important that these issues are sorted out. Otherwise, those hospitals like some in Bombay, Nanavati and others who came on and said, well, we are going to take charge, are suddenly cut to size as if they're criminals or as if they are villains. So I suppose this issue has to be sorted out, and I'm sure it will be. But if the private sector is required really to join in a big way in this, we'll have to do that. And I think 85% of care is provided by the private sector. So it is important that they are involved, otherwise things will not work out. Those are just my thoughts. You're welcome to react, Dr. Reddy.
No, I have no particular difference of opinion that we need to work together, both the public sector, the private sector, and the voluntary sector. And we need systems which will actually bring out the best of everyone and build in synergy as well. I fully agree that we need to have thoughtful decisions, quick decisions, but thoughtful decisions, which actually eases the way for everybody. But one of the points you made is about the general practitioner. It is true that 85% of the people with COVID will actually need management in primary care. They're not going to be requiring hospitalization. And that is where our neglect of primary health care in urban areas as well as rural areas, but in this case, particularly in urban areas, is actually proving to be our Achilles heel. We have not invested in the urban health mission, and we have not built up our primary healthcare system or our referral systems linking primary, secondary, and tertiary care. So it is those areas of neglect that need to be urgently redressed now and on a long-term basis.
Thank you for those very valid points. And I move to Dr. Priya again. We have a few minutes still. I know you're an expert on masks. I've been reading some of your work, Dr. Priya. Would you like to comment on masking, which itself has become a big sort of issue, and now everyone's on the same page, but what exactly is the masking strategy that countries should adopt?
So, we always used to say, if you're not sick, you don't mask. But again, COVID has turned everything up on its upside down. And we realized that up to 50% of people with COVID could be completely asymptomatic or shedding virus before they have symptoms in the 48 to 72 hours before they become sick. So masking, I think, needs to become a way of life. It can definitely spread of infection. What kind of masks? Ideally, a surgical mask is what would be the most effective. Now, those are in short supply the world over, so a cloth mask is the next best option. They're not as good as a mask, but they definitely do reduce the spread of infection, and that's what we should all be doing. In addition, it's really important when you have a mask, one of the things that happens is that you're constantly adjusting it, you're touching it. So doing good hand hygiene, carrying hand sanitizer, and washing your hands or cleaning your hands after you've touched the mask is also very, very important. And as far as social distancing, I think we're looking at some form of social distancing for the next several months. I have a question for some of the other panelists in India. One of the things that we're seeing less is very, very high death rates in the elderly. And a lot of that is in nursing homes, which is, not like the nursing homes in India. They're places where the elderly are taken care of, kind of like in a semi-hospital situation. I have been thinking about this. I have family back in India. For older people in India, staying home, kind of semi-lockdown all the time, isn't that unusual. It's part of life. Most of the elderly are taken care of at home by family. Do you think that's playing a role in keeping the mortality lower in other places?
Dr. Mithal, would you like to answer?
Yeah, at least in urban India, thank you, Mridhu. Thank you, Priya. At least in urban India, in urban middle class India, that is true. That elderly, the message that elderly are more prone, the message that people with diabetes are more prone and heart disease are more prone to the serious outcomes that are associated with COVID-19 has gone across pretty well through the media and through other mechanisms. So I do think that by and large, I see it all around me. The elderly are within the safety of their family. But that we're only talking of a small part of India. In many other parts, there's no way you can there are 7 people living in a small room. You can't think of either social distancing or elderly. And if it starts hitting those patches like it has done in Dharavi, in Bombay, it's going to be a tough ask. But yes, in typical urban middle class India, yes, by and large, elderly have been within the same home, and they have been kept sort of protected, and that may be a factor why we are seeing less mortality in India.
Right. And I think Mr. Munjal was earlier trying to make a point, especially on the public-private healthcare collaboration bit. Mr. Munjal, your audio wasn't up at that point in time. Was there a point you wanted to make there?
Actually, it was a question for both Poonam and for Priya. We keep hearing about the potential and possible treatments. It would be useful to hear from Poonam what's going on in the Solidarity trial that's going on around the world. And we know that there are many vaccines, new drugs, formulations, as also repurposing trials going on around the world. Could Priya tell us a little bit about what's going on in those trials? That would be helpful. And I can come in later if you like about the role of private sector and why maintaining our economy is as important as maintaining the health of the people in each country.
If I can, before you start to answer that, Priya and Poonam, what is happening on the plasma therapy trials bit? We have seen 1 or 2 cases in India, critical cases that have responded well. Is that a viable solution at all till we find a vaccine? And what are the pros and cons, the risks and challenges involved with
that? Did you want to go first?
Now, as far as WHO is concerned, yes, we did try to get together 400 experts from around the world to see how we could now focus on a solidarity trial where certain medicines and drugs were identified. In fact, 4 of them were identified, which could help in addressing the problem of COVID-19. At the moment, we have no conclusion on that because even drugs which we thought could be helpful in certain trials have not proved to be helpful. Therefore, WHO is not yet sure of what would really work. As far as vaccines are concerned, yes, there is an accelerated movement on vaccines, recognizing that perhaps is one way in which, or the only way in which, we could be addressing this problem of COVID-19. There are 8 vaccine candidates at the moment, which WHO is sort of coordinating or is aware of, where countries, in a situation like this, countries are free to join this trial or not. It's their option. But yes, many countries around the world have shown interest in it. Especially in the Southeast Asia region, we have 3 countries which have the manufacturing capacity and which have shown an interest, and these are India, Indonesia, and Thailand. There are 8 vaccine candidates which are now being followed up very carefully. We do hope that there would be a vaccine which would come out, say, in about 2 years. That is the time period that is needed for a vaccine. Now, we do know that there are certain manufacturers who are saying that they'll be able to come up with a vaccine earlier, but we still have to see that. You've all heard about the Oxford University, which has the technical know-how, and we have heard of one of the pharmaceutical companies, a very prominent one in India, which has teamed up with it for production. And this pharmaceutical company has the reputation of producing 1.5 billion vaccines a year. In fact, 60% of the children immunized around the world get vaccines from this pharmaceutical company. However, at the moment, we are not in a position to say that this would really happen, though it's being said that this may come out much earlier than 2 years. In the Southeast Asia region, I had a meeting of the vaccine manufacturers just 10 days ago, where vaccine manufacturers were invited from 3 countries of the region which have the capacity to produce vaccine. And I'm referring to, again, those 3 countries, Indonesia, Thailand, and India. And we did have 21 of these who joined us virtually, where they were sharing with us the different stages of vaccine development. And we, again, had this private sector company from India, which is very hopeful that it would be able to come up with a vaccine. So, and they are talking, of course, of December. But as far as WHO is concerned, we are not in a position to say that there would be a vaccine very early. We are looking at a 2-year horizon, recognizing that a vaccine takes much more time than that.
Right. And Poonam, if I may also bring in an audience question at this point, the question is that, in fact, it's a statement that an audience member has just made that I think the WHO could have played a much more effective role in the early stages of this pandemic. What's your point of view on that?
You see, we've heard a lot about this, and as far as WHO is concerned, the first we heard of influenza-like symptoms in a country of the world was on the 31st of December. That's when WHO was informed that yes, there was an outbreak there. And after that, WHO has been involved with it. We have sort of, yes, there was discussion, and I think when people raise this question, they're talking about the declaration of a public health emergency of international concern, that why was COVID-19 not declared as a pandemic earlier than it was, and why was it not declared as a public health emergency of international concern? Now, this is decided by a committee. It's not really WHO which decides. There is a committee which gives, yes, its own recommendations to the Director General of WHO, who then takes a view on this. In hindsight, it's often very easy to say that this should have been done or that should have been done, quite rightly, but at that point of time, WHO did what WHO thought was the right thing to do. So I do believe after that, we've been very active in this. We meet regularly. I think every evening we have a video conference with all the regional directors and the DG of WHO and those involved in emergency response to review the situation, to see what guidelines should be coming out of WHO. WHO has been providing a lot of operational support to member countries. In fact, there have been requests for supplies, which WHO has been giving regularly to countries. And looking at the distribution of supplies, we try to reach out to countries which are more vulnerable than the others, the smaller countries which have...
Absolutely, Poonam, we are all in this together. And at this point in time, of course, we are running out of time on this particular conversation. But I want to perhaps give the final word to Mr. Munjal here, who's been instrumental in curating this conversation with all stakeholders. Mr. Munjal, your closing thoughts as we, step into the next phase of this pandemic, lifting the lockdown in many parts of the country in a phased manner. Your thoughts, final comments.
Thank you. First, a big thank you to all the panelists and to both the anchor and the moderator. This was a very useful conversation. It is clear for all of us right now, this is not a problem which is going away tomorrow. So we do need to figure out a way to balance lives and livelihoods and learn to live with this while we maintain all kinds of precaution and the advisories that we get every now and then from the officials, from government, from medical experts, etc. And for our own survival, for our own enlightened self-interest, we need to ensure that all of us, when we are at home or in public, are following at least a minimum amount of the precaution, even inside our home, to make that second nature, make that a normal habit. So wearing a mask, washing our hands, everybody has spoken about this. I just think it's important at the same time for governments to step forward, as they are doing in many countries, to ensure that livelihoods are maintained as well, that financial support from government, which is our last resort at this moment, when the economy is kind of falling around our ears. It is important that we provide fiscal support, significantly more fiscal support than we have done earlier, to ensure not just that the most vulnerable in the country are protected, which they must be, but also the economic engine of the country, the small industry, mid-sized industry, and also large industry, which all of them have a symbiotic relationship, and that we can maintain people's jobs, their salaries, wages, livelihoods, and their ability to protect themselves and their families. I think it's important for us to find a balance as we move forward and gradually keep on opening while maintaining all of the good sense that has been informed to us by medical experts, as also by the authorities. So I'd like to thank all of you very much for being here with us for this panel, and hope you will be available again at another occasion for the Mind Institute. And
Yes.
the Mind Mondays will continue every Monday at 5 p.m. to bring us subjects of deep interest of what's going on with us today and also how we look at the future.
Absolutely. Thank you everyone for joining us today. Mr. Munjal, Poonam, Priya, Dr. Mithal, Professor Reddy, thanks very much for those very, very valuable insights today on Mind Mondays. Of course, we'll be back next week at 5 p.m. again. Till then, thank you very much for joining us. Goodbye and stay safe.